Thank you so much, Alexandre, and thank you all at NeuroWork Brazil and Brasilia College for inviting me today. It is an absolute pleasure. I'm delighted that we can have this broad discussions and that I can share our work. And I hope that this will be informative, that this hopefully can inspire more people to work on photobiomodulation and possibly some collaboration. So the title of my presentation is Fundamentals of Transcranial Stimulation by tPBM, which is a short acronym for transcranial photobiomodulation. All right, so with that, these are my disclosures. I'm the co-founder of a company, NeuroWork Therapeutics. However, I'm not going to present any data about any of the devices of this company, and I have some patents through Mass General Hospital, although the hospital really owns the patents. So I guess the question is, why another treatment modality? And this course really is, I think, critically important because you guys are learning about all modalities of neuromodulation. And so what is the place of these modalities? And what, if any, is the place of photobiomodulation? So I'll take the example of depression. And if you think about the treatment of major depression, you can see here that 3/4 of the people in the United States that suffer from major depression were never treated with antidepressant medication. So now the antidepressant medications are the mainstay, the first line treatment for depression. Now, some might be treated with psychotherapy. However, the reality is that there are not many very well trained psychotherapists with evidence-based therapies. So a large chunk of people go untreated for a variety of reasons. People don't like taking medication, people cannot afford psychotherapy, and or people don't have access to psychotherapy when it's evidence-based psychotherapy. So it's a huge gap in treatment, and this is just depression. But this is true for many other conditions in terms of psychiatric disorders, and some neuropsychiatric condition or neurological disorders don't have effective treatments. So we can't continue doing the same old thing in terms of treatments, just relying on medication and other interventions that are like talk therapy. We need to bring new interventions like devices. However, the devices, of course, we know they are effective. ECT, TMS, TMS is approved for OCD, is approved for major depression in the United States, it has other medical approvals. And yet we cannot just rely with or into in-office treatments, because that's not going to satisfy that huge demand that I just showed you about. So that's why there's a huge gap, and we need to think at something else. Now, photobiomodulation is one of those opportunity for at-home treatment. There's opportunity for in-office treatment, but also for at-home treatment. And so I want to tell you a little more about photobiomodulation, what it is, and what our experience has been. So first of all, is the use of light. We're all familiar with visible light, but here, of course, we're familiar with ultraviolet, high energy light, and the high energy light is somewhat a dangerous light. The light that we use in photobiomodulation is, however, low energy, is below the visible, is infrared light. So the beauty of this light is that you see the the visible spectrum with the different colors. And you see that this is fairly well absorbed by either hemoglobin or melanin, so by the pigments in the skin. Now, as you go with towards the wavelengths that are larger wavelengths, which is the infrared, you see that the pigments absorb less, which means that there is what we call an optical window, a window in between roughly 800 and 1200 nanometers, where there's less absorption by different pigments or different components of the tissue and greater penetration. That means that if we put the light on the forehead or put the light on the head, about 1 to 2% of the light, depending on the parameters, might penetrate to the brain. When it reaches the brain, the light reaches the mitochondria. And of the mitochondria in the outer membrane, it reaches the respiratory chain. Eventually, that light leads to an energy transfer, very similar to the photosynthesis, very similar to what you see in the plants. And that energy transfer leads to greater energy in the cell with ATP. Funny enough, the cell also produces light, here indicated as biophoton. And there's lots of speculation about the relevance of this light that the cell emits. And there's a downstream effect, which is eventually cell proliferation, cell differentiation, antioxidant, anti-inflammatory effect in the cell. What this means is that there are a variety of effects that we call neuroprotective. In fact, some I told you already, antioxidant effect. There are neurotrophins that are produced by the cells as a result of the light. The cell is more resilient and less likely to die, and less sensitive to excitotoxicity. Also, as a result of the neurotrophin, there are more synapses produced. There is an increase in neurogenesis, and also effects which are anti-inflammatory can affect the blood flow. So increased blood flow, increased angiogenesis. So all of that could potentially benefit the brain. So now, coming back to us, how did we even get to this? Because I can tell you in 2009, I wasn't thinking about photobiomodulation. I was thinking about treating my patients in the community as a psychiatrist. And what I knew is that my patients didn't like what I had to offer. They didn't like my medications. As a matter of fact, they thought they could be poisoned by my medications. And they were scared to death by the side effects of those medications. And I was back then also working with the depression program at Mass General Hospital. And at that time, the Mass General Hospital depression program was very interested in mitochondria and energy metabolism. What then became even more obvious is that when depression hits, there are many issues related to the mitochondria. There are changes in the morphology of the mitochondria. There are changes in their function with decreased production of energy, which then leads to all sort of negative effects, like more inflammation, more cell death, less plasticity. And on the contrary, antidepressants kind of revert some of these effects. Back then, a colleague of mine, Juiz, had shown that when an augmentation with SSRI and thyroid or hormone was given to the patients, if they responded to that, their nucleotide triphosphate, which is analog of ATP, increased. And instead, people that did not respond didn't have any change. So that kind of further the point that if you can induce metabolic changes, you could um, help depression. And you know, and because I just told you that photobiomodulation can lead to energy transfers that are actually leading to an energized neurons and brain. So with that, we started a study. This was our first device. This was the NeuroThera device from the company Phototera, which was a laser device that we were moving in different spots. You see here A, B, C, D. We're peeling these spots one by one and putting the light for a fairly brief time. It was a very potent laser, up to 700 milliwatt per square centimeter. And we were giving 6 sessions. This laser was used in patients with stroke back then. And unfortunately, that trial on stroke, which was very large, over 1,000 patients, these were 3 sequence trials, led eventually to negative results. The company bankrupted. We didn't have funding for our study anymore. So that's why we only had 4 patients in this study. But what we saw, even with very few patients, is that on average, their depression score improved over time in a significant way. We were very impressed by that. And then we found this other device. This was a company, this was the Omnilux device from Photomedics. And this was a company that produced a low power device that was actually used for wrinkle treatment. That's all we could get back then. We were not able to afford any high power device. So that was a shift in our research. We kind of put those, as you can see, the best we could with the hairnet. We tried to aim at F3, F4, because we wanted to aim at the dorsolateral prefrontal cortex. Then we kind of restarted again. And since the study was the same, was elated, we call it elated 2. And what we saw was striking. And this very tiny, simple, safe device had a remarkable effect here in red, in terms of antidepressant effect, which separated from here the sham. This is a very well-controlled study, differently from the first one we did. So we were excited, and we decided to continue. At this point, you know the pattern. If those were elated 1 and elated 2, this was going to be elated 3. We were confident about it. We said, okay, we're going to replicate these findings with our kind of friends and colleagues in New York. We're going to do a 2-site study. We're going to have a much larger sample size here, almost 50 patients. We kind of figured what the parameters were. We tried to be close to the other parameters. We know that the other parameters worked. And then we said, okay, let's distribute this. We'll get a little bit on the close to the dorsolateral prefrontal cortex with these 2 sites here. And we'll get some at the frontal poles with these other 2 sites that I'm pointing here. So this was a real device, this time planned for depression. And the company that was sponsoring the device was Lightcure. So now we started also a more complex trial, which was longer, up to 12 weeks. So what we saw, much to our dismay, was there was no difference whatsoever. You see here, NIR was blue, orange was sham. This was the first phase, the first 6 weeks, and then the next 6 weeks, phase two. So that was kind of surprising at the very least, and we had to rethink the way we had done this. The best we could come up with was the fact that there were some issues here. This was a rigid device. A lot of the light here from the higher sites was on hair. So that means that the hair, especially color hair, were shielding the light. So there was less penetration. And also, the light was distributed on 4 sides instead of 2, which means that every side was receiving less light, which might have also been an issue. And also frontal poles are somewhat distant from the dorsolateral prefrontal cortex, which even that leads to less deposition of light at the brain target. So we might have done something wrong here, and I think the data show it. Now, from there, we're lucky enough that despite those negative findings, we were funded by the National Institute of Health to look at 3 doses. We kind of knew that we needed to be more precise in our understanding of the effect of the dose, and that just looking at clinical effects was going to be imprecise, miss the mark. So we said, okay, well, let's then make sure we have several doses. The low dose was supposed to be something fairly similar to what we had seen in the ELITE-2 study. And at this point, we were thinking, also given the ELITE-3 study results, we're thinking this might or might not work. The medium dose was a dose that was higher, not very high, but other groups had shown some effect, for instance, in terms of cognitive benefits with the medium dose, and we thought it's going to be better. And the high dose was going to be our best shot, high enough to make sure that we can, for sure, go through and get to the brain. Of note, this high dose, you see that on average had the same intensity, 300 milliwatt per square centimeter. However, it was on a duty cycle, means like the light goes on only for 1/3 of the time, which means that all the energy has to go during that time. And so you get a peak, which is 3 times higher in terms of intensity. And also the duration of this exposure was twice as long. It was 10 minutes instead of 5 minutes. So the total energy was much higher. So that's how we decided. And we had now a very simple makeshift device that you can see here. Was primarily made of plastic and a glass fiber optic that we used because we needed to get into the scanner. We needed a device that would not be causing artifacts in a magnetic resonance machine. We wanted to look at biological effect. We wanted to move away from those clinical effects that were somewhat imprecise. And of course, we wanted multiple doses. So again, as I told you, this was the low dose. We look at that and we try to look at the effect on blood flow measured by BOLT in the MR. You see the BOLT signal before the stimulation and during the stimulation. So immediate changes. Now we had a sham control. And fortunately, the sham was doing what was supposed to do, meaning showing no effect whatsoever. There was no sham effect. However, very surprisingly, the low dose that we thought wouldn't really do much was in fact producing a biological change, was producing a decrease in blood flow. So that dose that had failed in a later three was still engaging somewhat the brain function. Then we went on and we went to our medium dose. That was the dose that we thought, based on the literature, should be good enough. And again, we did one session with that. I told you about the sham, I told you about the low. We definitely expected some biological changes with the medium dose. And we did find biological changes. However, this time, much to our surprise, the change was just the opposite of what we had seen with the low dose. With the medium dose, we were producing an increase in blood flow. So very unexpected. We didn't quite theorize that photobiomodulation could be radically different or opposite with a lower dose and with a higher dose. Finally, we tested the high dose, which I told you was twice as long, 10 minutes, same device, same patients. And what we saw here is what I've shown you already, is that the high dose didn't make any difference. And this was our best shot. This is what we thought, wow, we'll just go through with this. There will definitely be enough energy to the brain, but no change. This is not entirely foreign to the field of photobiomodulation. We know that also in other models, in animal models, for instance, it's possible to give a dose that is just too high. And by doing so, losing the effect and sometimes getting the opposite or counterproductive changes. We didn't know that this would be possible in humans, that even in humans, you could get fairly easily to a dose that would be just too high. So I just wanted to say here that it's a little more complicated than that, in the sense that in the study, we were asking these patients to come back every week and get every week a scanner with a different dose. So if you look at the effect of the week, you see fairly consistently, though, that the medium dose increased from pre to post, or pre to stimulation, here in gray, and if the low dose decreased the signal in yellow pretty consistently across the 4 weeks. So that accounts for the effect of time. We managed to get some also scores for depression. And here you see that basically 1 week after we looked, okay, is there any change at all? I know that 1 week is just not enough. In depression, you need sometimes 6 or 8 weeks to have a full response, sometimes even longer. But can you see anything at 1 week? And so this was a sham. This is the difference in score for depression. Sham was roughly around 0, so no benefit. The high dose was very close to sham. However, the medium dose, surprisingly, even after just a week, was producing some benefits. So they were statistically different in terms of change in severity of depression compared to the sham. And the low dose also significantly different than sham. this was a little bit um, difficult for us to understand. How could two doses that had opposite biological effects both lead to a fairly similar therapeutic effect? More obviously to understand here, I don't have all the answers for you today. And here are again the week by week changes. Overall, you can see that over time, over the 4 weeks, scores tended to decrease at the MADRS. However, overall, you can still see that fairly consistently. For instance, here in yellow, sham, I'm sorry, that's yellow sham here. I hope I got the color right before. Let me just double check. Yeah, so yellow is sham here. So gray, I'm sorry, sham is blue and yellow is slow. Okay, good. Just wanted to make sure we're on the same page. And so here blue is the baseline and yellow is sham here, and here gray is slow. Colors are not consistent, but you can see that and there's a tendency low outperform, for instance, sham. Now, so that was our journey into photobiomodulation since 2009 up to these days. And we are, for depression, we're actually about to launch another trial where we're going to bring the medium dose to testing over 8 weeks. So the story is still going on, and I'll have more information in the years to come. One thing that happened, which was a kind of a side story, my background is really in depression and anxiety, and I haven't worked in the past in neurodevelopmental disorders. However, something happened to us as we were starting to publish our results that a friend of mine, a colleague in Italy, from where I am, in actually in Sardinia, in Cagliari, had heard about this treatment and wanted to try with this patient. He had several patients that had no treatment whatsoever to improve their cognition or their mood, their behavior. And so he asked me some suggestions, and he managed to get those little Omnilux devices, the ones that were for skin wrinkle that we put under the hairnet. And he managed to do the same thing with some of his young patients with Down syndrome that had no treatment option really from a neuropsychiatric standpoint. And so he did this 4 treatment, or 2 treatment per week for 2 weeks, and asked the patient to draw his face. After 14 days, after 4 treatment, this is what this 80-year-old girl drew, which is, you see, a much more centered, much better defined picture of him. And then he went on, he did up to 1 month, and this is what happened. All of a sudden, this doctor found that he had grown arms and hands and everything's, they had ears now. And then he did another cycle, and that's what happened. So something was there, something about motor skills, something about creativity, something was happening with these patients. He also treated a 13-year-old boy, same. This time he asked to draw this spiral. The baseline, you see, was off-centered, not well delineated, but after a month, much better. Um, so again, something was happening. He ended up treating several patients and also following these patients for years, and with occasional news cycles. And he found a striking improvement with better cognitive function, better school performance, better socialization. The speech was definitely improved. Motor function, speech and motor function might have the same reason for improving, but also, strangely enough, some physical characteristics also were improved. So that led our group eventually to pursue this further with a group here that is partnering with us in Mass General. This is my team here. We have decided to pursue treatment for language with photobiomodulation in individuals with Down syndrome. Language is a huge impairment, and because of that, learning is also slow. Of course, there are other reasons, other neurocognitive reasons in Down syndrome. So we were lucky to be funded by a European group, the Down Syndrome Research Foundation. We're very grateful for their support. And we decided to test, similarly to what we've done in depression, test whether we can engage a biomarker. Again, we know that when we get too excited about just looking at clinical benefits, it was sometimes might get in a challenging spot where we choose one dose and the dose we've chosen might or might not work. There's something to be said about proving the dose with a biological biomarker. So we wanted to increase gamma power through EEG in adults with Down syndrome, and also see if there were clinical effects, also not only language, but in attention and memory, see if there was a correlation with increasing gamma power and those cognitive and language improvements. And on the side, we were going to repeat MR to look at connectivity, especially for the language network. So this is the device we use this time. It's not a laser device. It's not a high-power device. It's a cluster device. This MEDEX device is used for bones and joints and muscles to treat osteomuscular problems, especially chronic pain or wound healing. But here it's repurposed for with multiple clusters. We had one set as sham, one set as treatment, and nobody knows, so it's all double blind. And this is the position of the clusters. We position them on the left side on key areas that are involved with language. Why EEG? We wanted to look at EEG because, first of all, it's somewhat difficult sometimes to run in MAR in patients with neurodevelopmental disorders. And an EEG might be less claustrophobic, somewhat easier to accept, but also our group had seen, in fact, that even in healthy subjects, one session of transcranial photobiomodulation here in red was able to increase the power density after treatment compared to the blue before treatment on gamma waves. So we thought, well, this is something we know we can alter. We have preliminary data that supports this biomarker. And of course, interestingly, like in Alzheimer, even in Down syndrome, this biomarker is depressed. So the power of gamma waves is decreased. So this is a study that is still ongoing. We are actively recruiting, and we'll have more on this in probably in a year from now. Well, I guess you might understand how we have evolved in a fairly serendipitous way. There's a certain randomness here, and on the same line, our involvement in Alzheimer's disease is something that we didn't dream about until a few years ago. Came about as we were clearly a center specialized in clinical interventions and translational interventions. And we were witnessing that other centers had demonstrated in healthy subjects cognitive benefits for memory, for attention, for executive function, also switching tasks. So it became obvious that we were well positioned, together with our partners in crime from New York University, well positioned to start a new endeavor in a field that was also very new for us. And there was an enormous demand because of lack of treatment, as you can imagine, for Alzheimer's disease. Now we have some new approved treatment, like monoclonal antibodies targeting beta amyloid. But back then, there was not even that. And so there was this incredible need, a lot of opportunity related to fundings in US to support research in this direction. And we were able to team up with our institutional neurology department, both at Mass General and New York University. So we use the same device that we are now using for the depression study. I told you that we are now in a depression clinical trial for 8 weeks of treatment for a patient. And we decided to do the same for the Alzheimer's disease. We call this study TRAP-AD. You see the device now with the 2 sources. Now this device has a ferromagnetic component, is a much more solid device than the ones you see in the scanner. But this is a device that we need to use every day, so it needs to be more robust and harder to break. And also, we don't care if it's ferromagnetic because it doesn't go into the scanner. So we are planning to enroll 125 subjects. So we have a couple of years to go still. And our goal is very much a clinical goal. We want to see if there are cognitive benefits. This is rigorous, double-blind. This is the view of the device from inside. You will see the light comes through these cones. This is one patient that consented to show the picture. See how the device looks over the forehead. It's really a helmet, and it's aiming again at the dorsolateral prefrontal cortex bilaterally. Now, I told you before already for the Down syndrome study and for the depression study that after the lessons and the failures we experience, we always want to make sure we have biological proofs. So besides the scans that we do for characterization, we also do MRS, magnetic resonance spectroscopy scan with phosphorus at baseline and at the end of treatment. After 8 weeks, we repeat this. And that's very important because, as you might remember from the beginning, The phosphorus metabolism is what you expect to be altered by photobiomodulation. And so hopefully if we energize the brain, we'll see indeed a change in this biomarker, which might correlate with improvement in cognitive function in these patients. We also follow these patients for 3 months to make sure that if there is any benefit, that these benefits are actually maintained. Again, a close-up of the device. You see, this is a big console. It's a heavy device, definitely not a wearable. This is still what you see here, the in-office version of this clunky, bulky devices. So how did we manage to get to bipolar disorder? So this was actually a fellow of mine that was interested in this. There was a call for a study in bipolar disorder and for new interventions. This call was from the Milken Institute. We were interested. He was interested, and I was interested for different reasons. I was thinking, besides the improvement in mood and depression, besides the improvement in cognition, can we actually tweak the light and use the light in different ways to have other type of dimensional improvements? And so in that sense, we're thinking, well, what if we were to stimulate the dorsolateral prefrontal cortex over the right forehead only? Can we, by doing so, actually improve the cognitive control? And by improving the cognitive control, hopefully lessen the impulsivity in patients. So we're thinking about, again, the dorsolateral prefrontal cortex on the right, and we, like others, like Mary Phillips and like George Almeida, we were very much trying to target this right side to counteract some hypomanic symptoms. But also, we want to do so within 5 days. This was a kind of a limited budget study, and also hopefully see if there are changes in blood flow similar to what we demonstrated in unipolar patients. We do tasks, Delgado and Iowa, to look at impulsivity and see if there's any change on that. This study is very much going on still, and again, it will take us probably more than a year to have more results. But what I wanted to tell you, it's a little bit our story, how this has been evolving on our side, and what do we see? What do I see about the future? These studies are about testing biological engagement and testing clinical benefits for photobiomodulation. However, what I told you at the very beginning is that there is a huge gap, and that gap can hardly be filled by treatments that are delivered just in office. With just too many patients, it's just too difficult to get them in office, sometimes too expensive for the patients to come in office. People don't have time. So the future direction, what we see as an opportunity here is to have clinic. We have a clinic at Mass General, and this clinic is so far an in-office clinic. Yet, the clinic, we see more and more are clinics that allow the use of platforms, remote interventions, remote communications with telemedicine. We're all familiar with that. And this is something, it's a growing field. It's something that is absolutely possible. And what I will say is that photobiomodulation is ideally suited for this. Of course, there are other techniques, TDCS, TACS, but photobiomodulation, it's easy. You don't have to wet sponges. You don't have to worry about positioning electrodes. Just put it on and turn it on. So we think, or I think, that this is an incredible field, and this can really fill an important gap. To summarize here, is just the wearability, the scalability, the safety that really is amenable to online clinics. There's also digital power, possibility to integrate with other sensors. Our patients start to have more Fitbit, more Aura Ring, and more other sensors. If those are connected, there's also the possibility of kind of informing the treatment with those sensors. There's possibility of real-time changes if patients have access at home to their dose rather than having a need to go in office if they feel suicidal, if they're craving for substances. The treatment is right there if they need it. And also the evolution of this treatment is potentially related to the evolution of software, which is a fast-paced evolution compared to the evolution of the CT machine or the TMS. So that's in a nutshell what I wanted to tell you today about our story, our hopes for the field, for helping patients and increasing wellness. So this is our team, a little part of our team. There are many more people involved. We're at a walk of Alzheimer, and we have social media as well. You're welcome to follow us on social media if you're interested. If you want to scan this QR code, you can also have access to all of that. I know we are 10 minutes to the end. I think with that, I will end and I'll take questions. Thank you.
Professor Cassano, thank you so much for a very interesting lecture. It's a pleasure to hear you again. I already watched all your lectures available online on YouTube. So it's a really pleasure to have you here telling us about the history being made about photobiomodulation. So thank you so much. I already had written a question, but I believe the interpreter will ask you my question. So please, interpreter.
Eu vou ler a pergunta para os alunos. No caso de pacientes com síndrome de Down tratados com fotobiomodulação que apresentaram melhora cognitiva, esses ganhos foram mantidos? Essa foi uma pergunta que está ali no chat.
Yeah, so if the treatment is not continued, the understanding is that these improvements can be lost. There are several examples of that. Some are the data on chronic traumatic brain injury. Some are the data on chronic traumatic encephalopathy. So like football players, if the treatment is suspended after 2 to 4 or 6 weeks, the treatment benefits are lost. However, because these treatments are amenable to wearable at-home treatment, it shouldn't be a problem to maintain these benefits.
Eu não sei se eu posso fazer pergunta em inglês ou em português. Alguém me ajuda aí, por favor, que aí eu
Yes, of
posso
course,
perguntar
ask,
diretamente.
Pode fazer em português.
Tá certo, perfeito. Eu vou perguntar em português e ele responde em inglês. Professor, a respeito do uso da fotobiomodulação em casa, né, ou seja, de forma remota, como a gente ainda não tem total domínio a respeito dessa dose, né, e dos efeitos, principalmente dos efeitos biológicos, é possível que a gente vislumbre num curto prazo que isso possa ser algo mais generalizado, ou seja, que as pessoas realmente possam ter isso em casa para poder fazer, para poder se tratar? E mais um complemento da pergunta. O senhor falou a respeito do closed loop, né, do circuito fechado, onde o paciente ele é continuamente monitorado e aí o equipamento ele se ajusta às características do paciente. Eu imagino que talvez fosse um eletroencefalograma, por exemplo, né, monitorando continuamente, e aí a fotobiomodulação ela ia, por exemplo, sendo entregue em diferentes, talvez, frequências ou diferentes intensidades. É nessa linha que o senhor mencionou um equipamento dessa forma?
Yes, so that's the idea. It could be some sensors that are specifically directly recording from brain function. It could be also sensors that indirectly are influenced by brain function, like heart rate variability, for instance. So it doesn't necessarily need to be a direct signal from brain function. It could be indirect, and those could be used. And it doesn't have to be necessarily in real time. Because you might say, you might consider the recording of HRV over the past week and realize that the patient maybe didn't respond to the antidepressant dose as well as you thought they would. And then, you know, the algorithm or the algorithm and the clinician decide that a dose increase is warranted. Did I answer your question?
Yeah. Thanks. Se vocês não for perguntar, pessoal, eu vou continuar perguntando, porque eu tenho uma outra pergunta, então eu vou deixar o pessoal perguntar aí. Bom, se ninguém vai fazer, eu vou fazer. A gente percebe, por exemplo, a questão da fotobiomodulação, hoje, aqui pelo menos no Brasil, né? Nós temos uma quantidade muito grande de pacientes com depressão, cerca de 30 milhões de brasileiros hoje com diagnóstico, fora os que a gente não tem diagnóstico ainda, né? E a gente percebe que a gente tem resultados nesses pacientes com uma dose muito, muito baixa. Os equipamentos que nós temos disponíveis aqui no Brasil, eles têm aproximadamente 8 miliwatts por centímetro quadrado por LED. Só que o que acontece é que nós aplicamos uma quantidade grande de área. Então, a gente a gente abrange uma área muito grande da cabeça do paciente. Então, assim, no final, a quantidade de joules que é aplicada é uma quantidade relativamente boa, mas por LED nós temos uma quantidade pequena de energia. Como é que explica isso? Como é que esses pacientes eles têm, porque eles clinicamente eles apresentam melhora, né? Pelo menos é o que nós temos visto aqui. Mas eu não consigo entender isso plenamente pelos efeitos biológicos.
Yes, so I actually agree with you, and the reality is that we cannot fully understand how that can happen. And I think this is really where the field is. You came to our NGH brain PBM rounds, and you saw that really the whole field is puzzled with the fact that very low intensity devices can make a difference, because that low intensity 8 milliwatt per square centimeter is not sufficient to penetrate to the brain. So there is a lot of discussion about this being remote effect instead of direct photon deposition effect. So maybe a remote effect on the blood flow. And that's possible. However, I want to caution people from oversimplifying things, because this is, at the end of the day, it is an electromagnetic phenomenon, right? The photon is, and so there might be also other effects, whether it's small currents or electromagnetic changes, field changes that might have a direct effect, or I should say, a neurostimulatory effect that is not remote blood related, and it's not direct in the sense of photon deposition mediated.
Ok. Tem pergunta aí. Viviane, você quer ler as perguntas? Tá sem microfone, Viviane.
Desculpa. Nós temos aqui algumas perguntas. Vamos lá. A Maria Baltazar perguntou quanto à medicação para depressão, fotobiomodulação tem contraindicação? E por quanto tempo, quantas sessões podemos aplicar para um efeito duradouro? E duradouro por quanto tempo?
Yeah, so first, there's no contraindication to use medication and photobiomodulation. If anything, we have seen that it could counteract some of the side effects of medication, for instance, sexual dysfunction or some cognitive side effects. And in terms of number of sessions, we started seeing some benefits after 2 weeks, after at least 4 sessions. For lasting effect, again, there are no good trials to answer this question, because all the trials we've done so far are short trials, and there's no long follow-up. Long follow-ups are very expensive, very difficult to do. However, in our experience with our clinic, you need people to do a treatment per week at the very least to maintain the effect.
Obrigada. Aqui a gente tem ainda a pergunta se tem indicação para transtorno opositor desafiador.
I see. So I think this is the I think it's the oppositional defiant disorder. So yes. So I think there is a growing interest in using this treatment in children during developmental age. Um, our group is actually working on a review paper of the literature. There is mostly evidence for autism, and definitely in autism there are some behavioral conduct problems, especially in low functioning autism. The patients with Down syndrome also had improvement in their behavior with less tantrums. So I think overall, it's reasonable to think that this could be tried. It's a very safe treatment. I would do that. It's always best to do it in the setting of a clinical trial. But if there is a clinic run by experts and there is a clear consent with the family and patients, of course, that can give their assent as well, then it's reasonable, to offer that given the level of safety, as long as patients and their family understand the options and the risks, if any.
Temos a pergunta se a fotobiomodulação pelo canal auditivo pode melhorar a função coclear.
So it has been tried. So there is literature about transtympanic membrane photobiomodulation. I will have to double check the results on that. I haven't followed this literature as much, but you could definitely look on PubMed. I know that it has been tried.
Fotobiomodulação para dor de cabeça crônica.
Yes, so in fact, photobiomodulation, interestingly, the very first treatment can induce a mild headache. So it's kind of a fleeting headache, usually for less than 30 minutes. But overall, there are case reports about using photobiomodulation for migraine, for instance, and sometimes for intractable headaches. It's not an indication yet. It's not approved for that, but it is an interesting and promising field.
Fotobiomodulação apresenta alguma contraindicação relativa ou absoluta, como, por exemplo, em pacientes com câncer?
Yeah. So this question has been looked at, especially the group of Michael Hamblin has looked at this aspect about cancer patients. I'll say a couple of things. According to their review of the literature, there's no evidence in humans with cancer that photobiomodulation would worsen their cancer. The other aspect that is interesting is that photobiomodulation is used in patients with cancer that are treated with chemo to treat their mucositis and their buccal ulcers. So, while photobiomodulation, it's at very beginning, at least for the transcranial field, there's no indication that it would consider a greater risk for patient with cancer. To the other question of whether there is any absolute contraindication, what we are concerned about is the fact that it might increase blood flow. We know it increases blood flow. And so for people who have clipped aneurysm or have intracranial stent, we would have to be a little careful about it. In prior conversation with neurosurgeon, they thought that the increase in blood flow was not worrisome to the point of justifying kind of taking precautions. But it's a point of carefulness, something to consider. And also, most of the time, the stents are placed far from the source of the light. So the effect on that vasculature could be much less. So there's no proof that this would be concerning, that something like a serious adverse event has happened or could happen, but it's something we are considering carefully in our patients when we definitely ask if they have any history of, if there is anything that is implanted. Finally, if they had a hemorrhagic stroke recently, like in the past 90 days, then we don't treat them. That's because of the same reason. We don't want to take a risk of inducing a second bleed and relapse. But again, there's no proof that this would happen either.
Posso fazer a última pergunta aqui? A última não, porque parece que a Irene tem mais uma. Eu tenho percebido nos nossos pacientes aqui com depressão, que inclusive estamos fazendo a pesquisa junto com, né, o pessoal deles, né, com o departamento deles, que os pacientes que têm uma depressão classificada como mais severa, eles melhoram muito mais, por exemplo, na escala de Beck, que é o que a gente utiliza aqui para fazer essa avaliação de intensidade, né, dos sintomas depressivos, do que os pacientes que têm uma depressão leve ou moderada, no caso. Então, não sei se você tem percebido as mesmas reações aí nos pacientes que você tem tratado, mas nós começamos agora com pacientes com depressão, mas praticamente todos que nós tratamos que têm uma depressão mais severa melhoram muito. E os outros não melhoram, mas não têm uma melhora tão expressiva do que os pacientes que têm a depressão profunda.
Yes, so that's certainly a known phenomenon. In clinical trials, pharmaceutical clinical trial, you want patients that are at the Hamilton 17, they're at least 17, scoring 17 or scoring 19. You want, 14, kind of the moderate and higher. It's a little too low. The challenge is that if you are not severe enough, there's a flooring effect, and the flooring effect means that you can't go down enough in terms of severity. There's not enough room for improvement, if you wish. Also, you have to keep in mind that while you might improve several symptoms, you might cause worsening of other symptoms, right? Because with antidepressants, at least you can worsen cognitive function, or you can worsen sexual functioning. So it's hard to see a remarkable improvement if you don't come from a more than moderate level of severity. Also, people who are kind of a low grade, experiencing a low grade depression, sometimes they are, some of the same ones are having kind of a chronic type of depression. And some of them might have chronic, fairly resistant depression, where they might not be very impaired, but they still tend to be quite symptomatic. And so also those are factors to consider, which might lead to somewhat more disappointing results.
Então, vamos à última pergunta, que é o que o senhor pensa a respeito da fotobiomodulação intestinal?
Yes, so photobiomodulation into the abdomen is definitely a field that is growing, with some Australian colleagues being pioneers. Dr. Anne Liebert in Australia is very interested in that. Their results are quite surprising. They have been treating a case series of patients with Parkinson with kind of a mix of transcranial and transabdominal photobiomodulation. They've shown some effects on the microbiome, and they definitely have shown improvements in Parkinson. I mean, I don't need to explain to you the gut-brain relationship and how trendy and meaningful this is in terms of inflammation, oxidative stress, and the possibility of a remote type of intervention, therefore, through the gut. It is surprising, again, when you think about penetration, that this would have any effect. I think, in all fairness, we need more studies. They're better, larger control, sham control studies for transcranial photobiomodulation. At least I'm not aware that there is the same rigor yet of experimentation for transabdominal photobiomodulation. Again, some intriguing preliminary data. It's certainly a field to follow. Yet, I don't think there's any conclusive evidence.
Podemos finalizar, Viviane?
Sim, sim. Uhum.
Okay. So, Paulo, thanks again. I know it's very hard to find a schedule with you, but it's for us. It's a pleasure to listen your experience, answering all the questions. So thank you so much. I'm very glad you are here with us. And maybe sometimes we in the future we can schedule you to be here presentially, in person. It will be very, very great for us. I know that NeuroWork has a congress next year in 2024, and maybe we can bring you here to join us in this very, very pleasant congress. So thank you so much. I want to thank you in English so we can talk directly. And I'll thank you in Portuguese also, so the students can understand. Pessoal, só agradeci demais o professor Cassano pela excelente palestra. Eu acho que, assim, para mim, é uma referência máxima na área de fotobiomodulação. Dificilmente a gente tem uma pessoa tão experiente, tão tranquila em compartilhar os conhecimentos quanto o professor Paolo. Então, assim, para mim tem sido um aprendizado realmente com ele. Ele faz questão que eu não chame de professor, que eu chame pelo nome, e isso para mim, assim, é uma honra muito grande. Então, eu aqui gostaria de deixar os meus agradecimentos à Viviane, que, né, teve comprou a nossa ideia de fazer essa aula, e eu acho que para todo mundo foi muito bom, né? Espero que a gente possa ter mais momentos como esse. Então, muito obrigado, professor, e espero que a gente possa se falar mais constantemente. Muito obrigado.
Thank you, Alexandre, and thank you, Viviane. Thank you to all of you that have been listening and asking this thought-provoking questions. It is an honor, that I had the opportunity today to kind of bring my experience to all of you, and that you gave me this opportunity to hopefully have some collaborations to move the field forward together with you. Thank you.
Ok, muito obrigado. Pessoal, acho que é isso, né? Você quer falar alguma coisa, Viviane? Quer finalizar? Por favor.
Quero agradecer, né, ao professor Paolo, ao professor Alexandre, que, né, tornou isso possível, trazer todo esse conhecimento para a gente aqui. Eu estou saindo animada, talvez a palavra, para colocar cada vez mais em prática, aí durante a aula pensando, puxa, mas aquele paciente, aí a gente vai fazendo as conexões, pensando quantos pacientes podem ser beneficiados, que é o meu objetivo, né, fazer com que cada vez mais pessoas sejam beneficiadas destas técnicas que que não têm efeito colateral, que não tem... né, não precisa ir do medicamento, né, não necessariamente pode precisar do medicamento, então eu estou saindo daqui muito animada, eu acredito que, né, todos os demais participantes devem estar com essa sensação, uma sensação muito boa de saber que tem gente que está ali pesquisando para a gente colocar isso em prática. Então, é o meu agradecimento, assim, de coração.
Então, pessoal, muito obrigado. Boa noite para todos. Professor, a gente vai se falando a respeito das pesquisas, né? E vamos continuar essa parceria. Muito obrigado. Boa noite a todos. Tchau, tchau.
Boa noite, tchau, tchau.
Thank you.
Ok, foi.